Hello and welcome to this episode of sMater, a podcast by clinicians for clinicians, brought to you by Mater, an Australian leader in healthcare for more than a century. I'm your host, Gillian Whiting.
And I'm Dr. Maria Bolton, GP specialist and former president of AMA Queensland.
Today we're talking about ovarian cancer, and we have two guests joining us, Dr. Nim Cabraal, a gynaecological oncologist at Mater Hospital Brisbane and Mater Private Hospital Brisbane, and Margaret Gooch, one of Nim's patients.
They will be sharing Margaret's journey, her diagnosis and treatment. We also discuss what pathways are available for all patients and the research making a real difference to Queensland women.
We are Mater.
We are Mater.
We are Mater.
This is sMater.
Nim and Margaret, welcome to sMater.
Thank you, Gillian and Maria, for having me on again.
Yes. Yeah, and thank you, Gillian and Maria. It's good to be here.
It's great to have you here. Now, you have known each other for a few years now, but it was a roundabout journey for you, Margaret. Can you take us back prior to your diagnosis? So you were 64, you had some vague, odd stomach symptoms, and then had your appendix out.
Yeah, so I can remember it was the wet season up north, and I was visiting friends in Innisfail, and it was raining, and I was getting these stomach pains intermittently, and I thought there was something, actually thought I had something wrong with my lungs because it felt very odd. And I rang my brother, who's a GP, and I wasn't at home. So he said, look, if you're really worried, then go to hospital. And so I thought, oh yeah, but it's not that bad, so I won't worry about it. So I went home, and anyway, so a few days later I did end up going to the GP on the island and had some tests done, some scans, and nothing was uncovered. And then a few weeks later I thought I still had these pains, but they kept coming and going and moving, and I wasn't quite sure where the pain was. And so I ended up going up to the Mater in Townsville to the outpatients there and had some more tests done and sent home. And that happened a few times. And the second time I went to the Mater, the doctor on call there, or who was on, he said, did some tests, couldn't find anything. He said, look, maybe you need your gallbladder investigated. Can I refer you to a surgeon? I said, yeah, sure. And so I went to the surgeon, and I had another scan, and then I had a colonoscopy because I'd had a history of diverticulitis. And so he said, well, your appendix looks a bit swollen. I think we'll take that out. So
Right. Well,
that's what happened.
Well, as I said, it was a roundabout journey, definitely. So how did you get that ovarian cancer diagnosis?
So then during the operation, which I think was just a laparoscopy, he said that one of my fallopian tubes looked a bit fibrous, and he said he might take that out because I didn't need it, take it out and send it off for a biopsy, and that's when they discovered the tumour.
And had ovarian cancer crossed your mind? Like, how was it? I assume it was a shock for you.
Yes, I'd barely even heard about it. I didn't, it just wasn't on my radar at all. I'd never heard of anyone who'd had ovarian cancer. And so, yes, I was really a bit surprised.
And Margaret, you were living in Magnetic Island, which is, a beautiful part of Queensland just off Townsville. How did you end up under the care of Nim in Brisbane?
Oh, well, that was very fortuitous because I'd actually had been to see Nim as a gynaecologist. So she came up to Townsville once every 6 months, and my gynaecologist referred me to Nim.
Yeah, for a second opinion.
For a second opinion for something else. And then so when this discovery was made, my surgeon contacted my gynaecologist, who contacted Nim. And then I got a phone call from Nim, and I was amazed that she had offered to say that there's this particular treatment I could have, and she thought I might be eligible for it.
Now, Nim, when as a GP should we refer patients to a gynaecological oncologist versus a generalist gynaecologist?
That's a good question because, there's a lot of women have ovarian cysts. Probably, I think the statistics are about 1 in 10 women will have a surgery for some kind of ovarian cyst in their lifetime. And so it's really about what the risk of what you think the patient's risk of malignancy is. So functional cysts are very common, particularly in the premenopause, and many of these can be managed by general gynecologists unless they have overtly malignant features. And if they are benign, a radiologist will often call them something. So they'll say it's a functional cyst, an ovulatory cyst, a dermoid cyst, a hemorrhagic cyst. If they're named, they can usually go to a general gynecologist and can be managed. Malignancy in that age group is uncommon, but if cysts are very complex or otherwise worrisome, they should probably go to a gynaecologist. And then postmenopausally, I guess your index of suspicion is much higher that you could have a cancer, but still not always. So in that situation, you might use the cyst characteristics as well as tumour markers and I guess the patient in front of you, to decide who you send them to. A lot of the time, if you haven't picked up as a GP that it could be malignant, a general gynecologist will see them and then refer them anyway. Yeah.
And Margaret came to you with a diagnosis,
yes,
proven by biopsy.
Yes.
How common is that?
Fairly uncommon, particularly the way she came via a general surgeon, but it does sometimes happen that they've done an investigation and found something. More commonly, how people present is that they'll have these vague symptoms, much like Margaret had. They'll go to the GP. A GP will do a CT scan or some kind of ultrasound potentially as well that finds something of concern, and then they come to me, and then I usually do the rest, the biopsy, either surgically or radiologically, and sort of proceed on with care.
And bearing in mind that some listeners may not be medical, they may not be GPs, and listening to Margaret's story about how it was a roundabout diagnosis and she lost an appendix along the way, what are some of the red flags that people should be looking out for? Because, some of the symptoms are very vague.
And I think that's unfortunately the thing about ovarian cancer, that the symptoms are very vague. They're often mistaken for, bowel dysfunction, or I have, maybe a gastro bug or something like that. But I think for this, it's really, and all of us have those symptoms at any one time, right? Like I might have a bit of abdominal pain or a bit of bloating one day, but it's really the persistence of those symptoms that's a worry, or the progression of them. So that if your pain doesn't go away and they happen, like Margaret's, for weeks and weeks and weeks ongoing, you have bloating that increases again for weeks and months, you should go and get investigated. It's a sort of like a balance between not being hypervigilant and just being aware of symptoms, and then if they are progressing or persistent, to go and get them investigated. Yeah.
So persistence, progression, and I expect that some of them would be also incidental findings, correct?
Yeah. About 20% are incidental findings. Yeah. And that might be in that category of a scan is done for something else and then a cyst is found, or a ovarian mass is found and gets treated. Yeah.
Nim, you and your team treat patients from all over Queensland. And as GPs, we really want our patients to be seen as fast as possible. Are there any investigations that you prefer us do prior to the patient seeing you?
So, I think almost everyone will have had some imaging which is flagged that they would need to come and see us. So if you have a concerning ovarian mass on ultrasound, it's very useful to do a CT scan as well. And that's really just to look at whole body staging to see if there's spread. A lot of the radiology practices will say do an MRI, but I don't find that useful, and I can decide whether to do that. And it is a more expensive test, so at least a CT. And some blood tests would be good, usually some standard tumour markers. If it's in someone who's older, the kind of standard CA125 panel. If someone is younger, there are some other tests that you might do that incorporate the risk for other types of ovarian cancer in those patients.
And with a CT, do you mean doing chest, abdo, pelvis, the whole lot?
Yeah, ideally. Yeah. And if you haven't done it, it's something I would routinely order when they come and see me.
So back to you, Margaret. You have this diagnosis. As you've mentioned, you're living in North Queensland at the time. What was your expectation about how the cancer was going to be treated?
Well, I can remember talking to Nim on the phone, and she was suggesting that I have these 3 rounds of chemo and then the operation and then another 3 rounds. And I was just saying, well, why can't I just have the operation? Why can't I just go into hospital, get it cut out, and then I can just keep going because, I've got a lot of things to do.
I'm a busy woman.
I'm very busy, yes. And she had to explain to me that, no, it didn't actually work like that.
Is that quite common, Nim?
Yeah, I think, I mean, as much as I value surgery, because I am a surgeon, we know that a combination of surgical treatment and chemotherapy is the most effective treatment for ovarian cancer, and the sequence of which we do them, so whether it's surgery first, followed by chemo, or chemotherapy first, or, half of your chemotherapy first followed by surgery and half of your chemotherapy the second half later, like what Margaret had, it doesn't really make a difference. It's the surgical decision making is really about how much disease we can remove fully when we do your operation. So if we don't think we can remove it all up front, that's why we would do a chemotherapy first approach.
Around 20% of ovarian cancer patients will have a genetic variant in one of their 2 BRCA genes, either in their inherited DNA or isolated in the tumour DNA itself. Since August 2020, all patients with BRCA variants have been able to access the PBS-funded PARP inhibitor olaparib. A typical course of the drug costs $140,000.
And Nim, in Margaret's case, you used genetic testing to determine treatment. Could you tell us a little bit about genetic testing? I mean, we're all familiar with, for example, if you have an affected family member, genetic testing to see what the rest of the family's risk is, but you also do genetic testing on the tumour.
Yes. So that's actually really important, and it's been a bit of an advance in ovarian cancer. So now if you come and you've got an ovarian cancer, particularly the type Margaret had, genetic testing both of blood to determine genetic family germline risk is standard, as well as tumour testing. So with the blood testing, it's a blood draw, and it will check to see whether you have a panel of genes that might predispose you to ovarian cancer. Now, we can also test for exactly the same genes in the tumour, and what we find is that about 20% of the ovarian cancer population will have a germline mutation, which we'll find from the blood draw. And then an additional 6%, like Margaret, will have a mutation that's just in the tissue, meaning they haven't inherited it, but their cancers develop this mutation. And then another 25% or so will have a collection of other mutations that make them favourable for additional treatments that we have. So the reason we do all this genetic testing is, like Margaret, if you have any of these mutations or this favourable collection of mutations, which we call homologous recombination deficiency, then you're eligible for targeted therapies, which are a big advance in the treatment of ovarian cancer. In Margaret's case, she had olaparib, which is a type of PARP inhibitor. Basically, it helps to prevent the cancer from repairing its own DNA, so it induces cell death. And what we know is that having these medications after you finish standard chemotherapy surgery can massively improve survival, particularly in the patients who have these favourable genetic mutations.
Can we go into a bit more detail in a moment, but just still on the genetic testing, is it available to all patients, and is there a cost involved?
So it is for private and public patients funded by Medicare, so there should be no additional cost, and it's a pretty standard part of treatment now. So we will essentially order these tests once we have a diagnostic biopsy in most cases, and the blood draw will be discussed usually by the chemotherapy specialist when you see them for genetic testing. And sometimes, for some selected cases, we might refer on to a geneticist to discuss further.
And Margaret, to you, it took 5 months, I understand, but the genetic testing confirmed the BRCA variant in your tumour. What impact did that have on you? Was that a relief in a sense?
Oh, absolutely. It meant that I could have that particular targeted therapy, which is fantastic. But the added benefit for me was that it wasn't something that I could pass on to anybody, or it wasn't in my family history. So that was terrific for me.
That's comforting news.
Yeah, absolutely.
And I guess for us as GPs, we often take a family history from a new patient. What should we be asking patients who have, and this is to you, Nim, who have a relative who has ovarian cancer? What are the useful questions that we can discuss and then decide what the risk is?
That's a really important question, but also somewhat difficult to answer, because we know that maybe up to 50% of the people who actually have a genetically inherited mutation don't have necessarily a concerning family history. So that's why it's standard of care for everyone, irrespective of history, if you get a diagnosis of ovarian cancer. Now, if you're someone who doesn't have a diagnosis of ovarian cancer, then the things to watch out for are really a strong family history of either breast or ovarian cancer, because the two syndromes that are most common, which are BRCA1 and 2, give you a risk of breast cancer as well as ovarian cancer. And sometimes we see a predominance in families that they'll have breast cancer, and then you might have one person who gets ovarian cancer, and in other families, mostly ovary, and then maybe one or two breasts. But in either case, ovarian cancer risk reduction should be considered, even if they have never developed it at an appropriate age, and because it's the only effective tool that we have to reduce people's risk. We don't, unfortunately for ovarian cancer, unlike breast cancer, doing scans and imaging is not effective, and it has been shown to be not effective.
I think you mentioned the PARP inhibitors are one of the biggest advances in treatment of ovarian cancer, a massive increase in survival rates. What are the side effects? And maybe, Margaret, you could speak to this.
Yeah, well, there were very few side effects that I could see. I did feel a little bit nauseous, but that was the main thing, really, and tired. I didn't have that much energy. But as far as taking something every day for 2 years goes, I mean, it was pretty good, really. I had a pretty good run with it, actually.
So you were able to do this from home?
Yeah.
At Magnetic Island?
Yeah. The chemist would get the prescription filled for me and order it in, and would always have it there on stock. So, yeah, it was great.
And was that under the PBS? Are they available?
Yeah. So for that population that I spoke about who have these favourable mutations, it's a fully funded medication now.
Yeah, it was great.
And I mean, we all know there's all these new therapies. Are there any side effects that GPs need to be on the lookout for?
Look, I think yes, but also to be assured as a GP that when you're on these medications, you have very close follow-up with a medical oncologist. So you'd be seeing someone every 4 to 6 weeks, if not in person, via telehealth for monitoring, having blood tests. So apart from the usual side effects of any medication, I don't think GPs need to necessarily be too worried, but be assured that people are getting adequate monitoring.
Yeah, so that was really good for me, because I had a monthly telehealth with Dr. Catherine Shannon, and blood tests as well, and then I would see Nim every 6 months as well. So I was well looked after, very well looked after.
And you mentioned that. I mean, what was it that made your journey so bearable?
Well, yeah, there were lots of things, but I get very emotional about this because it's I get very emotional because of the level of care. It was so good. I mentioned to you before that, before I went in for the operation, the specialists came in and introduced themselves, and they all told a story, and I told them lots of stories about myself. They'd talk to me, and so before the operation, I sort of felt that they were treating me as a person, not just, sometimes you feel like, you could be just, I don't know, an experiment, but I didn't feel like that at all. I felt like a person the whole way through.
That's lovely to hear, because there's a lot of talk always about what patient-centred care, but that's what it is, isn't it, Maria and Nim? Yeah, that's lovely.
Margaret, this is, I suppose, a common question that friends and family normally ask. From your friends and family, what did you feel that you needed from them when you were going through your treatment?
I had everything I needed, really. I was very, very lucky in that my brother lives in Brisbane, and my brother and sister-in-law, very supportive. So I stayed with them for the whole time while I had my follow-up chemo. And Robert, being a GP, was able to make sure that I was physically healthy and well. And they took me to all my medical appointments and, treated me very, very well. I was treated like a princess, really. And then as well with Dr. Nim and Dr. Catherine Shannon, they were fantastic. And friends were amazing. I got little gifts in the mail and all sorts of things. People would give me gifts, and sometimes when I was in Townsville, on the island before I came down, people would drop in meals and just call in to say hello, and I'd find little presents. So it's just beautiful. I was so lucky. Very, very blessed.
What a lovely community you have around you. And Nim, is there anything that patients can do to improve their health before undergoing such a long journey?
Yeah, look, I think that's a great question. There's not, like a lot of people ask me about diet and, should they do keto diets and things like that. And unfortunately, at the moment, we don't have any evidence that that works. And I think undergoing drastic diet changes when you're going to have chemotherapy and surgery, particularly if you lose weight and muscle, that's not necessarily a good thing. But the one thing we do have evidence for, and really strong evidence, is that women who participate in regular exercise, weight-bearing, cardiovascular exercise during chemotherapy and all of these treatments do better than women who don't. And I think it's about maintaining weight, muscle mass, fitness, and then just general recovery. So if you do nothing else, exercise and participate in normal activity.
sMater is the leading treatment and research centre for ovarian cancer in Queensland, treating almost half of all women who are diagnosed each year. sMater treats patients located in Metro South, West Moreton, Darling Downs and South West Hospital and Health Service regions, as well as patients from North and Far North Queensland.
Nim, can we go into more detail about the HIPEC treatment through the study? Is it for every patient? Because we know sMater is only one of a few places where you can have this in Australia.
Yeah, for ovarian cancer, there's only 3 centres in the whole country, and sMater is one of them. So selection criteria for HIPEC are fairly tight because not every patient is suitable. But in general, we want people to have stage 3 disease, which means that they have disease that's disseminated into the abdomen but not beyond. So it hasn't gone to their chest or their brain or into the bones. And that's important because stage 3 disease is cut-outable, if you like, but other sites may not be. So stage 3 disease in reasonable health and have had chemotherapy first. So it's always done as an interval setting, HIPEC at the moment, and have had a good response to that chemotherapy. And of course, willing and able to participate in the HIPEC program, which is not just about the surgery, but also about the follow-up that we do, etc., for that program.
And how do patients get referred for the HIPEC program? Is it gynaecologists, GPs?
So usually it would be via our service. So either in the public or the private sector, you'd be referred to one of the gynaecologists who works at sMater, and then we would go through your case and see if you're eligible. And then when you come up for an interval operation, if you are eligible, you'd be flagged for the HIPEC program.
How did you go with the HIPEC treatment? How did you feel through it? Fine.
I was unconscious.
You woke up and you were fine. Everything good.
Yeah, I think, just... to me, it was just all part and parcel of the whole thing. So yes, I'm sure it was.
I mean, compared to the average, surgery for an ovarian cancer, people do have a little bit of a longer recovery. Like I remember you were a bit more nauseated than the average person, and you're in hospital maybe for a couple of days longer than the average person. But overall, it's really well tolerated because we do tightly select people. Margaret's very fit and well. She was kind of sail through the surgery and the recovery. But there can be side effects sometimes from it. So because of that prolonged recovery, the circulation of chemotherapy inside your abdomen whilst we're doing the procedure, people can get sometimes very nauseated, very unwell, their gut's slower to work. Sometimes that chemotherapy can affect their kidneys, and so their kidneys can take a bit of a hit and take time to recover. So for a few days, you might not excrete some of the fluid that's been given to you during the surgery. You kind of become a bit swollen and things like that. So that's all very tightly managed in the ICU. And then when you start to recover, usually about day 3, day 4, you go to the ward and recover and stay. But you did sail through most of that pretty quickly.
Yeah.
So can you go into a little bit more detail about the actual procedure itself?
In terms of surgery, what we do is preoperatively there's a bit of preparation as well. So you would usually have had a diagnostic laparoscopy to assess the volume of disease in the week or two before your operation. Then you get admitted the day before and we bowel prep you, and you get a lot of people visiting you, like renal specialists, and you have the bowel prep and you see the medical team and our teams and et cetera, et cetera. And then on the day of surgery, you come into theatre and you usually have an epidural put in by the anaesthetist, and you have lots of drips and things put in, some of which are done when you're asleep. And then the surgery is not dissimilar to the standard ovarian cancer surgery that we do, which is the goal is to remove all visible disease. So we take out whatever organ is required to do that. Uterus, tubes and ovaries are pretty standard. The omentum, which is a fat pad that sits over your bowels, commonly is infiltrated with cancer, and Margaret's was. And then any area of the abdominal skin that has infiltration. So this is a cancer that tends to spread in the peritoneum, the abdominal skin. So we would remove that skin wherever it's affected, up by the liver, around the abdomen, like the front wall, anywhere. And then occasionally we do bowel operations. So we'll remove segments of bowel if they're affected by cancer. Margaret didn't need that. And then so once all that surgery is done, hopefully we've got you down to nothing visible to the human eye, then we add chemotherapy. And in ovarian cancer, it's a drug called cisplatin, which is circulated in the abdomen. It's warmed and circulated for about 90 minutes post-surgery. Then it's drained from the abdomen, and then we check everything carefully and then start closing up. And then once you're closed up and we've got drains and all those sorts of things in, you go to ICU post-operatively for monitoring. Usually people are in hospital for a week to 10 days after, but I've had patients as short as 5 days who are, running to get out the door. But about a week is pretty average.
And how would you describe the impact that this treatment has had generally on treating patients like Margaret?
I think Margaret's had an exceptional response because her surgery and treatment was in 2022 and she is at present without any sign of recurrence, which is pretty amazing. So, we're 4 years down the track now. So that's what we hope to see with the HIPEC program, that we have these longer periods where people are not recurring and essentially, treating/curing their ovarian cancer. Now, ovarian cancer, having said that, is a difficult beast to treat. Recurrences are not uncommon. But Margaret's had this wonderful constellation of had stage 3 disease, had a good response to chemotherapy, had HIPEC, had good surgery, appropriate chemotherapy afterwards, and then this maintenance treatment. And here she is. Yeah.
There is so much research in this area, and you're a member of the Queensland Centre for Gynaecological Cancer Research, QCGC. That's based at the University of Queensland. So, keeping that in mind, can you tell us a little bit about research or what's happening, anything that you're really particularly excited about is in regarding treatment or diagnosis of?
We have a few current research trials. I think in the medical oncology space, I probably can't speak to it as much because it's a chemotherapy run by the medical oncologists. But from a surgical perspective, there are a few things that we do at MARTA. And one of the important things is biobanking. So now any woman who comes with a suspected or proven ovarian cancer, we request, it's always voluntary of course, that they would agree that some of their tissue would be stored for research purposes. So a portion of the tumour is reserved. And we know now that these cancer tumour specimens are going all over the world for research, and they're driving new drug development or new novel treatment development. So it's really important, not just around the world, but in Queensland and in Australia. So that's one of the really amazing things that MARTA does, and we really encourage all of our patients to participate in the biobanking process. A few other trials, we're doing this study called MRI spectroscopy, where if you have an ovarian mass, say, we're doing a special type of MRI scan, which is looking at different sequences in the MRI to see whether we can predict that tumour is a cancer versus a more benign cyst or sometimes a borderline tumour. So that's something we can't really tell with imaging. We can do a best guess, but sometimes until a cancer spread, if it's contained to the ovary, we can't exactly say that it is malignant or not. And then some of the other trials, so there's, I think, a study called ZOVA, which John Hooper's doing, who I think you had on this podcast, and that's looking at sort of a suitcase option trial for detection and treatment of ovarian cancer. So looking to see whether giving you an infusion can help us detect where your ovarian cancer lesions are, and then maybe using that as a drug target. And then one other study which we've opened recently is called sMater, which is really around that psychological wellness after cancer treatments, not just for ovarian cancer patients, but anyone we're following up at Mater is being offered the study. And you can just enroll, and it's an online program where you work through some modules which looks at essentially overall wellness after surgery and different components, because not just exercise, but sexual health, emotional well-being, sometimes familial well-being, management of menopausal symptoms. So you have information, and then I guess an avenue of where to go if like the online module stuff is not fulfilling all of your needs.
And that is so important, because as GPs, we find that, I mean, everyone's different, but some patients, when they're busy getting diagnoses and treatment, they're just so busy, and it's not till afterwards that they feel it and, the cancer diagnosis. And it is so, so important. I was just wondering, I mean, ovarian cancer is a beast. Yes. What's in the horizon in terms of early diagnosis?
Yes, I wish I could say a lot. At the moment, we don't have any screening for ovarian cancer. So we don't have like an ultrasound scan or a blood test that you can do that we think would pick it up early. There are some trials going on, and I would say that they're interesting, but then, I mean, there's nothing yet proven. So unfortunately in that space, nothing, but we obviously rely on people reporting symptoms and presenting when they are symptomatic. I think one thing that should be noted is that a lot of ovarian cancer is found later. So stage 3 is a really common place where people are diagnosed. So 60 to 70% of people are stage 3. That does not mean it's not treatable. So even it's not, although early detection would be desirable, even later cancer diagnoses are treatable.
There's so many positives to take out of this, particularly with treatment. And Margaret, for you, to wrap things up, how are you doing? So you're not in North Queensland anymore, you're living down here.
Yes.
How are you doing?
I'm enjoying the change. I'm enjoying life immensely. It's fantastic. I have, until recently, been working 3 days a week with QUT, and I'm probably about to start again soon. I have lots of hobbies, and as Nim says, I like to exercise a lot. So where I'm living out at Moggill, there's lots of beautiful walks. So I do lots of walking, and I've joined the local gym, and
Life is busy.
Yes,
That's
and I've
great.
joined a choir, and I love singing as well. So there's lots and lots of things that I'm very, very grateful for, plus all my family and friends that I'm able to reconnect with down here. So that's lovely.
That's wonderful. Thank you so much for sharing your story with us today. We are very grateful. And thank you, Nim, also for coming back to sMater.
Thank you. Thanks for having me again.
Thanks very much for the opportunity.
This podcast was brought to you today from Meanjin, the land on which this podcast was recorded.
For our listeners at home or in the car, or having a well-deserved break between patients, thank you for tuning in.
See you next time on sMater.